apologise for not being here, so you're under my care and control today. Turbulent times, changes in the end to say nothing. So we need to start sort of lift ourselves above the day-to-day challenges and try and look to the future, the middle and the further horizons. We're a select few in the room, few online, but we've got a good agenda. We're doing a part A and part B today. So part A is in public, and when I close that, I will ask the public. But that's where we're on today. So if I may, I'll just do the formalities. Can I check everybody can hear me okay? You hear me online all right? Silence is taken as good. Thank you, Mel. That's good. Somerset board meetings have been extended to 3 hours to make sure the committee does not miss anything. Obviously, that means participation is greatly appreciated. So if you have a thought, share it. Nothing silly. May not agree, but that's how it goes. The agenda pack with papers is available via mod.gov or directly from the council website from the link which was sent out to members. In line with the recommended meeting procedures, I'm requesting that all members and officers turn off all microphones and videos, but please remember to turn on the microphones and videos when you speak. This helps with background noise, call quality, and anything disrupting the meeting. When I invite someone to speak, could you clearly state who you are for the benefit of anybody who is listening to the meeting so they can identify who is speaking? Please can I also remind board members to use the chat function solely for committee business purposes, as it is distracting if there are other questions or conversations happening. Can I also warmly welcome any members of the public and media who are to join us today. I know there's at least one member of the public present, but I'm not. Finally, as agendas are now viewed electronically, could I kindly request that members and officers refer to the page numbers from the published agenda pack to assist all present in finding the appropriate information. Just in respect of housekeeping, there is no expected fire alarm, but should this happen, please follow the Democratic Service colleagues. They will lead the way out to the car park at the rear of the building. So, apologies for absence today. We have a few, I'm afraid. Councillor Bill Revens, Jonathan Higman, Chief Executive of NHS Somerset, Duncan Sharkey, Chief Executive of Somerset Council, Sarah Wakefield, Councillor Sarah Wakefield, the Cabinet Member for Adult Services, David Crew, the representative of the Chamber of Commerce, Hilary Robinson, the representative of registered care providers, and Peter Lewis, the Chief Executive of Somerset Foundation Trust. Online, I'm pleased to welcome Gerald Taylor, who's the Deputy Chief Fire Officer for the county, and Sarah James, the Non-Executive Director of SWAST, who represents the ambulance services here, and Mel Locke, the Director of Adult Care. I'd also like to welcome Alison Bell, Director of Public Health, for the first time to this meeting. Obviously, Gerald, you're welcome as the first time to the meeting as well. And finally, to Dr. Rima Makareen, who is the new chair of Somerset Foundation Trust. Very welcome. The next item is to invite members to declare any interests or to make them aware that a list of the committee members' personal interests as members of district, city, town and parish councils is available for inspection at the website. Does anybody have any declarations of interest they wish to raise at this point? Thank you very much. Okay. The minutes of the previous meeting have been circulated with the papers. It was held on 26th of November 2024. I don't know whether anybody has any comments they would like to make about those minutes. Are we all content with them? Anybody to the contrary? Okay, then those minutes are adopted and found correct. Item 4 on the agenda is public question time. We have received no public questions, so there is nothing further to say, and there are no things that have been brought to my attention this morning that anybody would like to raise, so we can move forward from that. in which case we will move on to our first substantive item of the meeting, and that is the NHS Joint Forward Plan. And I should like to welcome Leanne Field, Deputy Director, Strategy and Transformation for NHS Somerset, who will present to us, and David McClay, who's our Director of Strategy, is here in support. So Leanne, if I may, I will hand over to you. Thank you.
Lovely. Thank you, Paul. And yeah, hi everyone. So those who haven't met, I'm Leanne. I work for NHS Somerset, and as Paul said, I'm here to introduce you to the NHS or the Somerset Joint Forward Plan, which you'll hear me refer to several times as the JFP, because we do love an acronym in the NHS. I'm sure you're all aware. So I'm hoping everyone can see the slides okay. Yeah, perfect. Thank you. Move this that way so I can see them. Oh, sorry. So just to set about a little bit of the purpose of the Joint Forward Plan for you. Sorry. So the Joint Forward Plan sets out how the ICB will meet its population health needs. At a minimum, it describes how we and our partners intend to arrange or provide NHS services to meet the needs of our population. Apologies, typically IT stuff going on. And there are three key principles in terms of setting up the JFP. Now, those principles have been agreed in line with, thank you.
Now try.
Now try? Yeah. Oh, there we go. Never been told I'm too quiet, but apologies. So those three principles that have been set out to sort of develop the JFP, so they were agreed back in 23-24 with NHS England and a range of the 42 system ICBs that we have around the country. And the principles are there. And I'm really sorry, I can't seem to get rid of that Teams bit down the side, so it's blocking off some of the slides for you, so I do apologise. But the principle one is that it needs to be fully aligned with our wider system partners' ambitions. We build on existing local strategies, and it's delivery focused. So they're ultimately the three key principles that we look to develop this by. So this year, as we do every year, we've taken a refresh of the Joint Forward Plan, and we have to publish this by the beginning of the new financial year. Many of you will be aware that there is an ongoing conversation regarding a refresh of the NHS 10-year plan, and due to those ongoing national conversations, we have been instructed by NHS England to only take a high-level refresh of the plan for this year. And so that's what we've done. But within that plan, we've also outlined how we'll look to deliver the wider NHS commitments, address the core purposes for which we run within the ICB and the ICS, and also how we're going to meet our legal requirements, of which there are 17 statutory requirements that we have to meet. Those are very important. Those are the ones that we get our homework marked from by NHS England as such, and also those go into supporting the ICB annual assessment. And so the refresh this year has also taken a reflective glance on what we've achieved within the last 12 months. And I'm here today to kind of provide the assurance and the oversight of the plan for members. So just taking a reflective stance on what we've achieved within the last 12 months. And what I will say, this is simply a snapshot. This isn't everything. I wouldn't have enough slides to cover everything, but this is just some high level headlines. So within the ICB ourselves, we've had a focus on running cost reductions. That was mandated to all systems by NHS England to reduce our running costs by 20%, and that's been achieved throughout the last 12 months. We established the 5 priority programmes, and I'll go on in the following slides just to talk to those programmes a little bit more. What I will say within those priority programmes, we've made some really excellent progress in some areas, but we do recognise that in others we've not perhaps hit as many milestones as we were hoping to achieve. We have set out a new approach to programme and change management with a real focus on digital enablement. And that's been supported by the publication of our digital strategy, which has 3 clear missions that have been developed within that. One of our priorities is workforce. This is one of the areas where we haven't quite made as much progress as we were hoping for a number of reasons, but we've now had that picked up internally with an SRO in place to move that work forward. And we've carried out lots and lots of work identified to support system flow. So that's people moving in and out of our hospitals and our community services. However, we do recognise that our population are still experiencing undue delays in transitioning out of our acute facilities. We are really pleased to say that our teams are more integrated, working proactively to support people within neighbourhoods with a consistent, but we do recognise a consistent offer is needed. And a framework has been developed in our neighbourhood areas too, but we do need to do some more simplifying of that model and give it that public ownership that's needed. So looking forward to 25-26. So you would have all hopefully received an opportunity to review the draft joint forward plan that would have come out in February. And thank you to those of you who have provided comments, greatly appreciated. What I've done is I've taken those comments and they've been, I've collated them and they've gone into the final version. I sincerely apologise you haven't got a copy of the final version in the pack. It only hit my inbox yesterday from the designer and I sent it back with a few slight amends that I wasn't happy with. I do now have it back, so I'll make sure Chris and team get that so you all receive a copy of that and the supporting appendices. So we've now confirmed our 5 priority programmes, and they are clinical pathways, workforce, system flow, neighbourhoods and population health. The one change you'll see in there if you reviewed last year's plan is priority 1, so that orange box, which is clinical pathways. Over the last 12 months, we've looked at that as finance and resources, but we've recognised that actually finance and resources is more of an enabling function that should sit across all of these priority programmes. So we're now going to take a specific piece of work looking at our clinical pathways. And through taking that piece of work, we're going to look to kind of build our clinical care model, redesign it to make sure we're improving outcomes and effectiveness of all of these pathways. What I will say, we haven't yet identified which pathways. We are going to do a piece of scoping work to make sure it's clear which ones we should be looking at in the first instance. We'll continue over the next 12 months to take a focus on non-criteria to reside. So essentially that's people who are sat in hospital beds who don't need to be there anymore. So we're going to make sure we look to improve the process and the system of transitioning those people out of hospital and therefore reducing the length of stay within those beds. We're going to look to support that by developing a new model of intermediate care. And we're also going to review our bedded care needs. So looking at things such as virtual wards, which some of you may have heard referred to as hospitals at home, and looking at wider use of technology and how we can use that within the system. We're going to look to complement the work around system flow by developing a model of a multidisciplinary team support in neighbourhoods for people, and our immediate focus will be on frailty within that area. We, in line with NHS operational planning, we also need to look to reduce our reliance on sort of temporary workforce and agency colleagues, and looking further into the future to agree what roles we need going sort of 5-10 years forward. And then we're also going to look to expand our prevention programmes on hypertension, but also just to add to that, cardiovascular disease will also be in there as part of that programme. So what's next? So I've already touched on it, the new priority, which is the clinical pathways redesign. So we're going to take a full scoping exercise of that throughout Q1. In terms of the 4 remaining objectives, the 4 remaining priorities, as I've said, we haven't made as much progress in some of those areas as we were hoping to. So we're going to almost take a step back, review the objectives and opportunities within those 4 programmes throughout April, and make sure they're really tightened. So we've got a clear scope as to what we're working towards, so that we can evaluate our successes efficiently. We're also going to look at reviewing our reporting mechanisms to ensure that the programmes are delivering against the Somerset operational plan, and that's including, as mentioned, giving that greater oversight of our finances under each priority. And that's just going to ensure that we've got greater grip and control on all of these programmes going forward. So then in terms of governance, I'm here today to kind of give you hopefully the assurance and the oversight of the JFP, which we need to do. For those members around the table who attend the ICB board, we'll be taking it to the IC board on the 27th of March for final approval before publication on the NHS website by no later than the 31st of March. I'm also working with our NHS Somerset communications team, and we'll put out a full communications package and a mail drop, so strategic system partners have a copy of that and aware when it's been launched. And that's me there, Paul. I'm really happy to take any questions. Thank you.
Yeah, thanks, Leanne. Thanks for taking us through that. I'm David McClay, the Chief Officer for Strategy at the ICB. So as Leanne said, this is a light touch this year. So we're expecting the 10-year plan. It's labelled as spring, but that might be late spring now, I'm guessing, as we're into spring already. And therefore that will trigger a sort of reset of our overall strategies, we'd imagine. I think we're clear, certainly from an ICB point of view, that we don't expect the 10-year plan to take us off in a different direction, but it will have some emphasis on some priorities within there that might sort of factor in at a local level. But we feel we're in the right place in terms of the shifts to neighbourhoods, the focus on prevention, and trying to get care closer to home for people and really focus on outcomes. And that is in our overarching strategy at the moment, and it is in our sort of joint forward plan. So we're not expecting a major change as we go through the year, but we will need to do a reset as per the NHS England requirements. So that's kind of that. As Leanne's touched on, there's been a few areas that have gone well this year and progressed well, and the board's been cited on that. There's a few areas that we've had to pay attention to as the year's progressed, particularly in and around the workforce. And I think as we've gone through those, we've identified even more areas that we could do better together in terms of reaching across and joint working with the council, and particularly around neighbourhoods as that started to evolve from a health point of view, and we'll touch on that later on in the agenda. So the focus today really is to consult this board in whether or not the sort of plan that Leanne's outlined there is in keeping with the integrated care strategy as it is at the moment, and to take comment on that. Thank you.
Thank you, David. So any questions? Heather?
Hi, thank you. Thanks very much, Leanne, and thanks, David, for your comments. And it's good and clear. I had a couple of questions, if I could. I'm going to test an assumption. I'm assuming that the work that you're doing around the no criteria to reside and that one pathway, which is the system flow of getting people out of hospitals, is something that you're working in line with. Mel's got her hand up with Mel Locke. I'm sure that's I'm making an assumption that's a joint work that you've been doing on that. The second point would be to say the clinical pathways bit really intrigues me because, oh, sorry, I didn't say who I was. So I'm Heather Shearer, lead member for Children, Family and Education at Somerset Council. I never remember to do that, so I do apologise. And you said it very clearly, Paul, and forgive me. The clinical pathways really interest me because there are so many clinical pathways. That must be an enormous piece of work. We often think about the flow through acutes because that's one of the obvious ones, but there's all kinds of referrals, cross-border, the relationship between PCNs, the GPs and getting in referrals. So it just seems to me like an enormous bit of work on its own. So it's a kind of, it made me think, I should know this, but I can't know where to look for it, is to know what's behind those 5 blocks in terms of what does good look like, what are we trying to do on those 5 priorities. And forgive me, I missed the last meeting in November, so you might well have refreshed it then, but I can't remember where I'd find that. So it'd be good to know what's behind the 5 colourful blocks. And I think, yeah, I think that's pretty much what my questions were. It's how, where I need to go to look for that, because I really should know that and I can't remember.
Thanks, Heather. So just specifically on the pathways piece, over the next probably 8 weeks, there's a piece of benchmarking then to identify which of the pathways would bring the greatest gain locally. And there's a big focus on us certainly within health at the moment around waiting times and elective waiting times. So that's one angle on it, but clearly there are other pressures. You say pathways means different things and is broad in its scope. So we've got a piece of work to do around prioritising, which are we prioritising and with which lens are we looking at it? Is it from a performance point of view? Is it from a long waits point of view from an individual and citizens? Is it in terms of high volume, for instance, and it make a bigger benefit to the local population? So that's a piece of work we now need to do, because we've just reshaped that one. For each of the others, there's a sort of operational plan that sits alongside of this that contains more information in terms of what trajectories and performance metrics we're aiming to achieve for next year. But there is a need, for Leanne's got a plan for the next sort of 4 or 6 weeks in and around making sure we've got clear objectives for each of those 5 coloured blocks, because clearly we had sort of, it's almost a developmental year for most of them this year. But as we move into year two, then it's about the delivery. And so what will we see then, in specifically with regards to neighbourhoods by the end of the year? What are we going to see at quarter one, quarter two, quarter three in advance of that's the key milestones, and that's the work that's taking place between now, the end of the month, and probably then into the first 2 weeks of April.
Give me that's really helpful. And I guess another thing just to think about is it's very easy. You can see you've got 5 separate, really quite important things to be looking at, and I absolutely get that. The question would be, how far do you think, when you're analysing which of your clinical pathways to be focusing on, you said there's many different criteria you could use, would you be considering, if we do this particular pathway, that might help with the neighbourhood's aims, that might help with the population health aims? I mean, if you're not careful, you end up with a bag of eels. It's all connected together. But it's whether you can do any crosswork or whether you're looking at them separately.
Yeah, so just on that, you're absolutely right. So we're going to be kind of reviewing pathways. There's a few ways going, a bit of a wish list. What would people like to see? But actually, then there needs to be that real triangulation between data, what the data is telling us, what the quality of the service is telling us, wait times and things like that. So there needs to be that real triangulation piece, so that we can see where our biggest opportunities are. And I think what we recognise is that actually we can't do it all in year one, as this is a new one. So actually we then need to do a bit of a prioritisation piece as to which pathways will give us the biggest bang for our buck, for want of better terminology, so we can focus on some key ones for year one and actually set that process for the coming years, because the JFP kind of should take a 5-year stance, but we appreciate that might change slightly with the 10-year, but it's just that full triangulation piece as to quality, performance, finance, those sorts of things. So thanks, Heather.
Thank you. If we could take Mel Locke next and then Beja after that. Mel?
So, and I apologise I'm not with you today, but I'm full of cold and I decided you didn't want to catch that, so I'm sorry I'm not in the room. I'm Mel Locke, in case you don't know, Exec Director for Adult Social Care and Housing. So it is a start of 10. Yes, it's the year to do it, but I think that the challenge for us is how quickly we can be really clear at defining what we're going to do, how that'll make a difference to individuals and the outcomes, because I think that it's great writing a strategy, never a problem, but actually it's the action plan that sits underneath it that we need to keep track of and keep seeing. And I think that's the bit for me, that as a system we need to make sure that we, whether that's here, whether that's in different meetings, but we need to be clear about what we're trying to achieve, how and when we're going to make these achievements, and then if we're not making them, how we understand and swiftly change. And I think that's the bit that we haven't quite got yet, but I may be very wrong in that space.
Yeah, no, I agree, Mel. Thank you. And I think that's when the slides are saying we need to get that much better grip and control of these programs and actually measuring the outcomes and where we're not achieving what we thought we would, look at the risk mitigations and things like that. So in terms of the kind of reporting and assurances, I'm happy to work with David and Chris and the board to bring back to the board what you would like to see to assure you all of the progress being made. But you are right, there are other meetings where we do look at the kind of successes of these priority programs. But yeah, as I say, I'm happy to take that conversation and work out where's the best place to report back in on our achievements or where things aren't quite perhaps going as we planned. So more than happy to do that.
Thank you. Beja.
I'm Beja Bally and I'm a GP and I'm the primary care partner member on the ICB board. I just wanted to add, in terms of the clinical pathways, that the Somerset Clinical Care and Support Professionals group is looking at that prioritisation and is also linking it into the other priorities. So as an example, in our April meeting, we are focusing on frailty because we recognise that that's another major element of the work that we want to do. So we don't want to prioritise clinical pathways and completely ignore that. But there are also some other clinical pathways that have been identified as being the biggest pinch points between the different parts of the NHS. So things like paediatrics, where there's just the volume is such that we're not currently meeting the demand. So it is being led by a clinical and support group, professionals group.
Thank you. So Alan and then Angela.
Thank you, Chair. Just to kind of follow Mel's point in terms of the broader issues and how we kind of integrate the action plan, I think it's probably one for officers to take away and kind of come back with a recommendation, because it feels to me like this is the year of interdependencies. because they've got a number of different activities across a number of different areas, everything from colleagues with the BCSFE. Obviously, the council will go through its own transformation programme, and that will be significant. And of course, this plan as well, which has a significant element of transformation within it. So it feels to me as if there's a need to kind of look at all those interdependent activities, because I feel we could all be touching on areas, but in slightly different ways and directions. So it's quite a substantial piece of work that we need to put into the board's programme to work out how we have that debate in between meetings. It feels to me as if we're knocking on the door chair of a board workshop about how we marshal all those elements together into one place.
I think that's right. I do think that our chief executives are all working very closely together, which is one of our great advantages. So in some ways, the executive boards are working together, even if we only see it occasionally. So I'm encouraged by the fact that there is a sense of mutual purpose in trying to balance it up. And some of the plans, as you say, I mean, the council has now concluded its plan, but the NHS is still in its final tweaks and the pressure is still on us.
And Chair, if I may, just to follow up, apologies. I think David has kind of stolen the march here in kind of thinking around alignment of priority. So we have a conversation offline to be able to develop those and what those kind of alignments may be. But I think as well, the transformation plan for the council is still under development. So we have the opportunity to influence that. I would hate to think we've got £100 million worth of transformation in the bag already. That would be nice, but we're not quite there yet. So I think there is an element of influence we can bring to that across the system as well.
Thank you very much. Angela.
Thank you. Good morning, everybody. I'm Angela Kerr. I'm representing one of the representatives of the voluntary sector this morning. I just wanted to ask if I could have a tiny bit more clarity on Principle 2, supporting subsidiarity, because I had to look that word up. Particularly, what does that mean for system partners, so voluntary, community, faith and social enterprise sector particularly? I wondered if it means we're going to stick to our guns regardless of what National says, but I just would appreciate a tiny bit more on that, please.
Feels a suitably difficult question for me to pick up, so thank you for that, Angela. I think the key principle in there is trying to be focused on the local population. I think that's the key driver for us. And as I mentioned, we're expecting the 10-year strategy to be developed, and we're not expecting a huge deviation from where we are. So within that is a focus on then trying to, through particularly the neighbourhood work within health, and indeed working across with councils, try to understand and be clear about who is being able to represent and support those neighbourhoods and at a local level. So there's a clear thing for us around trying to be very much focused on the needs and improving the outcomes locally. And that's kind of one of the key principles for us. So that's kind of our interpretation of
it. Rima first, then Heather. Okay.
Thank you. So Rima McCarran, the chair at Somerset Foundation Trust, but I was also an ICB chair before, so I'm kind of steeped in this whole population health inequalities piece. My caution is that we don't focus entirely. It feels a bit NHS-y, this joint forward plan, fixing clunky pathways. But if we put it around the population, then we start at prevention, which does take in the voluntary sector and wider partners. It does take in the public health work, and it helps us focus on, I mean, ultimately, if you listen to national rhetoric, it's about fixing the NHS, and absolutely we need to do that. But that's the supply side, and we really need to be working on the demand side. What the population of Somerset really need is to be healthy, and to be healthy, they need access to good education and good employment, etc., etc. You know all of that stuff. So for me, it's about us building up the plan, and I'm talking about the execution plan as opposed to the joint forward plan, which I don't have a problem with, but around cohorts of the population. So, for example, if we took frailty, given the demographics of Somerset, that's a large chunk of Somerset. You might try and narrow it down by saying the frail individuals who have no support from friends and family, because that then brings all the partners in this room together beyond the NHS piece to support those parts of the population. And invariably, if you join up all the partners around that cohort, the halo effect is that you actually do it for everyone, everyone who falls in that frail category. But it does help in terms of implementation to focus in on a smaller number of individuals rather than trying to fix everything for everyone in one go. So that's kind of my word of caution, is that as we all move forward together as partners, that we think about that whole piece well beyond the NHS.
Thank you, Rima. That from the NHS. Do you want to answer that, David?
It was just to provide a bit of reassurance, Remus. It was nice to meet you, and thank you for the comment. As Burge has kind of alluded to, we're keen to try and shift on two fronts really. One is to be kind of more clinically led in terms of those conversations and prioritization, and then secondly is to be more attuned to co-designing the solutions with the public and indeed what's of concern to them. We've absolutely realised through the last sort of 12-18 months that there's a real kind of need to work at a cohort level, but also then to overlap some of these things so that we're not having one initiative on prevention, one initiative on population health, a different initiative on neighbourhoods, for instance. And Burge kind of mentioned that coordination through that clinical group. So very much welcome your input to that. But yeah, we've still got a journey to go. It's not perfect yet. There's still pet projects and there's still things that are slightly off-piste. And well-intentioned, I must add, but we are trying to converge on a kind of narrower set of priorities and indeed cohorts of the population within that. So thank you for that.
Thank you. So Heather, then Catherine, then Berge, and then I'm going to start to pull this together, if I may.
I'll be as quick as I can be, and I just want to start off by saying so many people say things so much better and more eloquently than I ever do, so I'm indebted to a lot of people for what they're speaking, and I'm particularly for Angela in terms of reminding me of something I fell over when I read the slides before, because that point, the principle 2, where quite rightly Angela asked about what it meant, I really didn't understand what that sentence meant at all. So I think it's something about if you can't tell somebody down the pub what it means or explain it really easily, then it's just like a watchword for for understanding. But yeah, and I guess when I looked at the 5 blocks, population health seemed to be the overarching thing of everything, as opposed to one of 5. But at this point, I think we need to start doing things. So we could argue all day about which block should be the front and the second and the whatever. And I think it's just great to start getting some delivery and some action in as soon as we can at the front end of this long plan. But yeah, just a bit of a plea for a simpler version of number 2 if possible.
Thank you. Hi, I'm Catherine Nolan. I'm Chief Executive Spark Somerset. So here, as Angela is, representing the voluntary sector. Just wanted to absolutely echo what Rima has said. I think it's really heartening to see that the voluntary sector is mentioned in the Joint Forward Plan, and we're really pleased to see it there. I think for us as a sector, though, we're still struggling to see our place in that. And I think actually to move to that next stage where we think about people and we think about the cohorts, I think we can then see ourselves, because I think at the moment, even around the neighbourhood work, it's around a way of working, it's around a structure and a governance, and forgive me for repeating me because many of you will have heard me say similar things before, but actually for lots of organisations, they still can't see what that means for them. I've also raised that I think there's concern, and it's been raised formally at the Mental Health Board, that mental health doesn't really feature as an issue either. So I think there's something here around us really clearly as a system explaining why we've come to the 5 areas that we've come to and what our plan is going forward to ensure that those really pressing areas of need are going to be included in the report going forward as well. But yeah, thank you, Rima. I absolutely echo what you say as well. Thank you.
Thank you, Catherine. You want to?
Thanks for that, Catherine. And we've obviously had conversations outside. So there is, I think, when we bring back the detail, particularly around, and we focused it today on the pathways piece, but as Rima's pointed out, there's a body of work around the population and the frailty and how that feeds into neighbourhoods. I think once that detail is there, then that should become apparent in terms of how the VCFSE sector best work with that. And in terms of your comment about mental health, absolutely it is within the plan. It's not kind of writ large on those 5, but it is woven into each of them. But we can make that more explicit when we bring it back in terms of the detail.
Thank you. Berge.
Yeah, I just wanted to add, just in terms of the frailty work, so the draft agenda for the meeting in April is looking at frailty with a specific lens around isolation and loneliness, and that's a deliberate ploy to try and stop us from thinking about things from a health perspective. And so I think starting the conversation with that hopefully will get us some outcomes that will be much more holistic in terms of the organizations of people that are involved and what it means, absolutely, and you know what is it that we're going to invest our resources and time in to be able to do that stuff, because there is otherwise, like I say, a very big temptation that we just go down the medical route and we just redesign a clinical pathway.
Thank you, Paige. May I just, I'll let one more, Liz.
Thank you, Chair. My name's Liz Leish and I'm the lead member for resources, procurement and performance, which is a fair load in a big council, and it includes all the finance. So I completely take your point about finance sitting across all the 5 colour blocks and being the enabler. I just want to make the point, while we're all working on transformational plans, we're also working as part of that on savings in order to make a more viable organisation for the future. And whilst that can pull us together, we can also fall over each other. So I just want to make the point that we need to work doubly hard to make sure we don't fall over each other at that point. Thank you.
Final pearl, if I might. It's absolutely classic. We all, when people are getting tight on finance, everybody breathes in and the gaps appear between us. We've got to be really careful to breathe out and keep reaching across those divides. One of the issues that probably came from a lot of that is that single titles in blocks can be misinterpreted, can't they? And you know, it's almost the word clinical pathways almost immediately defines it. If it was health pathways, maybe it would be more engaged. I don't know. I mean, far be it from me to interfere at this late stage, but I'm just trying to think about how we get everybody to feel involved even more in it in that way. Our task this morning is to review and receive this. So obviously there are a lot of comments which will hopefully be taken back by Leanne and David, and it will be incorporated as best they can. I hope also that people who want to follow through with things will feel free to get in touch, and if you haven't got contact details, then I'm sure we'll make sure they are there. I absolutely echo, this is a partnership effort, albeit it's a document that comes from one particular place. So I'm sure we'll work together. So are we happy to receive and we've reviewed it as far as we can today? Thank you very much indeed. Thank you, Leanne. Thank you, David. They're going to stay with us for the rest of the meeting. Is that all right? Fabulous. Thank you. Okay, so as ever, the time is completely shot, but there we go. We allowed ourselves extra time. If I may, then we'll move to item 6, which is the Better Care Fund. And I will invite Alison Raswell, the Director of Localities and Strategic Commissioning, to present some slides. And again, David is here to support her. And we will then see how we go. Thank you.
Thank you, Chair. And thank you everyone for having me this morning. So I recognise you've kind of had a bombardment of papers around this. So you've received a briefing on the Better Care Fund. You've also received a our appendixes for our submission that's due at the end of the month. So I've just got a few slides to take us through to summarise some of this. So just want to give you a bit of an introduction to the Better Care Fund, the role of the Somerset board and how you sign off plans, and actually where I'd really like to get to is having a bit of a discussion on how you can be involved in with this moving forwards. So the Better Care Fund is obviously a joint initiative. It's about improving integrated health and care, and very much sort of working together with the council and the NHS. It was introduced back in 2013 so that to provide better cooperation and obviously to help our population live independently for longer, and that's through trying to reduce hospital admissions and supporting quicker discharges from hospitals. So there's some key principles of the BCF. It's about, as I said, encouraging that collaboration, improving patient outcomes, so again making sure that people can have that independence and receive care at home as much as possible in the community rather than in our acute hospitals. reducing the pressure on those hospitals. So Leanne's already picked up in our BCF a piece of work that we're doing around system flow. And actually the BCF is very much part of that around the intermediate care service. It's about enhancing efficiency and supporting our social care services. So BCF is, again, there's some specific key objectives each year. The BCF objectives for this year are very much supporting the shifts within the 10-year plan. So looking at the shift from sickness to prevention and supporting people living independently and that shift from hospital to home. So the draft plan that you've got today, our submission that is due at the end of the month, is a draft narrative plan. We have already made changes to it. So we've had some feedback from our regional colleagues. So we are making some sort of final amendments to that, but recognising we would like any further comments from board members or members would be really, really welcome. We have to do a demand and capacity plan that hasn't been shared with you yet. We're still working on that. But again, we can share that with you. It's a very detailed Excel spreadsheet. So if you like your numbers, you're very welcome to review it. And we have a planning template, which has been shared with you, that looks at the expenditure from the BCF, but also looks at the metrics that we need to be looking at. So again, very much sort of we are monitored on this on a quarterly basis. 3 headline metrics for 25-26, which focuses on emergency admissions to hospital for people aged over 65 per 100,000 population. A focus on the discharges, on discharge delays with a new metric around DRD, which is discharge ready date. And from an adult social care perspective, looking at our long-term admissions to residential care homes and nursing homes for people aged over 65 per 100,000 population. So you're not going to be able to see, I don't think, the end of this, but we can share the slides with you. We are putting together a draft trajectory for emergency admissions. We've undertaken a detailed review of demand for emergency admissions since 1920, and we've seen an average growth of 1% per year. We know we have an ageing population and we do anticipate admissions to increase, but we are, as a system, putting in mitigations to try and reduce that as much as possible. And some of you will know, you'll be very familiar with the work that we're doing around our neighbourhoods, but equally around how we are doing that demand or admission avoidance. So looking at all the different things that we can do to support people to be at home and keep them at home and provide care for them at home rather than going into hospital, because we equally know that when they get into hospital, we then have the challenges on getting them back to the best place for them. And that kind of moves into the next area, really. So this metric is focusing on our, we have something we call no criteria to reside. This is replacing that metric, but we still have a huge focus around this. No criteria to reside is about people who are in hospital when they no longer need to be in hospital. And obviously we have quite high delays within Somerset. So we're doing a whole piece of work around system flow to try and reduce that. Our ambition for this, for our Better Care Fund submission, is to get to the national discharge ready date of 86.9% by September. So we've got a lot of work to do over the next few months to really get that into the right position. And then we have our long-term admissions to residential care homes and nursing homes. So again, with this metric, we are placing looking at the plan based on 23-24 out term. But we know that this is, again, a real challenge for us because of the impact of demography and the increasing numbers of capital drops that means that we're standing still. Capital drops, I will give that, I will give the definition of capital drops. So that's basically when somebody's own money drops below the threshold and they're therefore entitled to support from adult social care. So to the financial details then of the Better Care Fund. The fund for Somerset is just under 92 million. So that's obviously a considerable amount of money that we are looking at across the county. The vast majority of that, or just over half of that, is around supporting our intermediate care services. So again, if we think about the work that we need to do to try and improve the experience for people who are admitted into hospital, how we can get them the right support to be able to get them out as quickly as possible, because we know that if people stay in hospital, they deteriorate and it's not the best place for them to be. So there's a lot of work going on within our acute hospitals in particular to really get people, as many people home as possible, for those to go home with under their own sort of steam. But some people will require support at home, so we've got our Pathway 1 intermediate care service to support them. But some people we also know need bedded care, so we have bedded care available for them in our community hospitals and within our care homes. And then the rest of the spend is there for protecting adult social care services, looking at our LD services, investment in disabled facilities grant, and new models of care. So the request to you today is the narrative plan, which is draft. I recognise it's draft, and as I said, we are still trying to improve the narrative plan, but that is for approval today from members, and obviously we will give you a final version after submission. In order to sign off the plan, recognising the national team recognise that it's going to be a real challenge because of our operational planning taking place at the same time. It's a real challenge for us to get all of that done and through the relevant governance routes by the end of March. So they are supporting that we can get sign off from the chair of the Health and Wellbeing Board, which is obviously our Somerset board, our chief executives and our directors of finance. So we have that meeting taking place on the 21st of March. So again, we are seeking agreement in principle today from the chair to proceed as outlined above. And then just to say, I think there's a huge opportunity here. We recognise we probably haven't given as many briefings as we should have done to you as members of this board. That's something that we certainly want to improve moving forwards. We want to make sure that we can do that in a collaborative way. We have got an internal audit from our internal auditors taking place between the council and the ICB to review our BCF to see what opportunities that gives us moving forwards. So when that is conducted, we'd really like, if possible, to schedule in a workshop session with you to really look at this together to see what we can do to sort of see what improvements we can make to our BCF and see what the opportunities are moving forwards. That's it. Thank you, Chair.
Thank you, Alison. David, do you want to add anything?
Thanks, Alison. So just to underline a couple of points, really. One, as things stood previously, responsibility for this sign off and support was done through devolved responsibility into a joint commissioning steering group. Through conversations, we feel it's better, given the size and volume of the resource in there, it's better to have visibility and a bit more detail for the board itself. So hopefully people are comfortable with that. There's a lot of detail, so you'll be careful what you wish for, I guess, in some ways. So there's a lot of information in there. I appreciate that, and there's still some work to be worked through in terms of the final details of it. But some comment on the narrative would be helpful. The second point I just want to make is Alison's alluded to at the end is a kind of a tidying up of the fund needed. I think it's evolved over time. Many areas across the country have got into a similar place where they need to just sort of unwind it a little bit and understand exactly what's being funded from it. But you know, it's being used to good use at the minute. It's just having that clarity is what the audit is seeking to get to, and as I say, we'll involve this group in that outcome of the audit and any decisions thereafter. So very happy to take. I know Mel's heavily involved in it as well, so I'm happy to take further questions, but we'll go to Mel.
Thank you, David. But Mel, what would you like to add?
So I think the adding bit in there is you saw Better Care Fund has been going since 2012, and the starting point was around how does it support adult social care. So if you saw the £19 million approximately that sits in adult social care, that was always there to manage the amount of money that came out of local authority at that time. So that 19 million sits in our bottom line, just so that everybody's fully aware of that. There isn't money that can shift around. It was there, and the Better Care Fund was there too. support adult social care in that space. So if you're not understanding that, that's what it is. It's not, but what we now need to look at is the rest of the pot that we have, and is that being spent in the most appropriate way? And is there ways in which we can transform by using that money? And I think the audit will support us in that space. The other area in terms of the last metrics that they have there, which is around admission to admissions to residential and nursing care, absolutely. Depleted funds, capital drops, whichever way you want to call it these days, is a problem for us. So 48% of the new placements into our residential and nursing is from people that are already in there that use up all their money and then end up needing social care support. So that's a huge number, and it's very difficult once somebody is in that placement to actually, because they'll sell their homes, to find alternatives for them at that point. It doesn't mean to say you can't do it for the odd one or two, but it's very rare that you end up moving people out. So it's about the proactive work with our communities to help people understand what other solutions are there for them before they go into res and nursing care. And that's hopefully the work around the neighbourhoods and the work around communities that we will get going. And that may, for a small number, help us. Not yet, because people are already in and depleting their funds, but hopefully for the future.
Thanks, Mel. You might almost think things are joined up. Heather.
Steady on, being joined up. That's a marvellous thing. I'm sure we are. I'm massively supportive of this, and I'm sure any questions I ask, I'm sure I'll be happy with the answers, and I would be supportive of this coming here and signing it off in this way. So please don't take any of these nitpicky questions as me saying I don't want to do it. By any means, I'm very supportive. I'm also very supportive of there being internal audit look at this. I think that's great. So in general terms, I think, yes, I'd be very supportive of signing off here. I think it'd be great to come here, and it'd be lovely to down the line see the outcomes come back here as well. I mean, that would make loads of sense to me. Tiny things around the slide that you had with the 65 plus going into A&E and whatnot. There seemed to be a constant figure of 147,107 population, which never changed. There was an asterisk on one of the slides which I looked at before, and I couldn't see what the asterisk was telling me. So there's just, I'm sure there'll be some arcane reason why that number doesn't change, but it having looked at the stuff before, it looked a bit weird. So you can help me with that maybe later. The 65 plus is interesting. When I worked for a short while with Mel Locke on adult services, 65 plus is one set of cohort, but obviously an awful lot of people worry about the 80 plus. So I wondered whether we're doing the 65 plus because that's a national determination. So we're following a national thing, and it made me wonder as well. It's good to see split out learning disabilities and and perhaps just aging population. But I guess also it's that thing of when you're looking at supporting people out of hospital, there are also, say, stroke patients going out of hospital who may happen to be over 65. It's understanding what we're actually looking at. So I just found that a bit interesting to see. It's a very blunt instrument at the moment with just the numbers. Was a comment there. Oh, and the other one was the last bit, prompted by what Mel was saying and being reminded again that, of course, our desire is to keep people out of in their own homes for as long as possible. And so the metric, and forgive me because it's gone away and I couldn't find it again, but that metric about people going into long-term care, we kind of want fewer people going into long-term care, and they may be the ones that going in their 80s and not in their 65s. So it's just that thing about, do we have to be careful of metrics around long-term care when all that I know that we're doing across the system is trying to keep people at home? So is there something about tracking home care, domiciliary care as a metric? I don't know, but I couldn't see it, but just a thought.
Thanks, Alison.
Yeah, just to sort of word of caution that the template is the template, so that's what we have to complete. But I absolutely get what you're saying. There's a huge range of metrics that we look at through our intermediate care services to measure what we're doing. So and I'm sure we could come up with, we've got dashboards aplenty that we could probably share around looking at some of this. But I take your point about the over 80s, and that's something we could look at perhaps locally. But the template is a lovely national piece of work. So
It'll be interesting, won't it, when we move beyond being over 65 as being of an age where people need to be looked after. Heather, I'm 71. We are. Bert.
So I was also slightly intrigued by the data around the 65s for a slightly different reason. So I was looking at the 1% increase in admissions and thinking, how has our population increased over that time? Because I suspect that our number of over 65s has probably increased by a certain amount. I don't know whether it's 1%. And how does that compare to other areas? Because 1% seems quite low to me. And I just wondered whether there was a comparison between us and other areas in terms of both our population growth for the over 65s and also a comparator of our admissions for that group. But my other point is that in the submission, so your plan, the priorities that are in there are not identical to the plans in the joint forward plan, because priority 1 is still the old priority. Is that a deliberate thing? Okay, just wanted to check. Thank you.
Thanks, Bert. Catherine.
Thank you. This is just an offer really to Alison and to Mel and colleagues who are working on this. I probably should know what the involvement of the voluntary sector is in the Better Care Fund, and I have to say I don't know the detail, but I think it strikes me that we're talking about home from hospital, we're talking about keeping people out of hospital, that it's an area that the voluntary sector have a lot of knowledge and expertise around. And so for those who aren't aware, Spark hosts something called the Voluntary Sector VCFSE Collaborative. I love an acronym. And the whole point of that is to support and encourage and enable partnerships and collaboration between the voluntary sector and the public sector. And there are 50 chief execs who meet regularly. Angela's one of those, obviously, and Anna mine. We've got an independent chair, and it's a space where you've got chief execs of health and social care charities, essentially, who are supporting our communities, many of whom have got really good ideas about how we could do things differently. And so I guess my plea would be, use us, because we want to be involved, we want to be part of those conversations, and we appreciate it maybe that might enable some money to flow to the voluntary sector, but that isn't the only reason we want to be involved. I think those leaders want to be part of those conversations so that they can support change as well. So the offer's there, so please let me know. Yeah.
Thank you very much, Catherine. I'm sure equally with David, we'll keep triangulating that. Really important. Sarah James online.
Morning, thank you, Paul. I'm Sarah James. I'm a non-executive director at the South West Ambulance Trust. I was struck by, there was a line in the slide around the audit that referenced looking at opportunities to enhance working with partners. And I was just wondering what the thinking is around the range of what that might look at. So is it just around engaging initiatives, or is it kind of a broader thing, such as there are certain partners who will have, by the nature of their work, will have, and the obvious example I have in my head is paramedics, who will have some really good insight into what are the kind of things that lead to hospital admissions that might be avoided. So I wondered if it was going to be that broader, seeking out insights from partners around causes, as well as working together on solutions. It may be that the thinking's not that developed yet, but it would be good to know.
Thank you, Sarah. Alison?
Yeah, no, thank you, Sarah. I think that's a really good point. You know, we're always seeking, there's lots of work ongoing anyway to look at admission avoidance schemes and how we can reduce the amount of people going into hospital. So I think what we're hoping for is, once we get the outputs of the audit, is to really think about how that can support us with some of this work. So certainly we'll be looking, yes, we can look at a wider stakeholder group.
I think it's really important we do. I mean, I think the ambulance service has a lot to help with that, but joint working. Okay, and if there are no further questions, our task is to approve it in principle, but then delegate to the, who am I delegating to? The chief executives to approve the final version of it. Are we all content with that? Anybody to the contrary? Okay. In that case, thank you very much, Alison. Thank you, David. That's great. So if we may then, we will move on to Get Britain Working. Mel, I'm sorry we're running behind, but that's because we had a good discussion. So if I may, I'll introduce Mel Roberts, Work Health and Skills Service Manager, to introduce us to this. And it's a hot topic. It's happening increasingly all over the country, this work. And it's one of the things that I picked up yesterday in a presentation was that it's not about Get Britain Working, it's then about getting our localities working. And I'm sure you're going to build on that, Mel. Thanks so much. Over to you.
Yes, thank you, everyone. I'm Mel Roberts. I work for Somerset Council within the Economic Prosperity team. I'm also working closely with ICB and health colleagues, and hence my title, Work Health and Skills Lead. So picking up all activity really about getting people back into work, making sure they've got the skills to do the jobs that they want to move into. So I'm going to talk today about two related programmes. So one is about the Get Britain Working, starting off with a white paper, but then what that looks like in respect of a Somerset plan, and then part of a programme outlined within that white paper entitled Connect to Work. So I will talk through both quite briefly. So the reason for coming to the board this morning is the partners sat around the table today are referenced within the Get Britain Working activity, and we are really keen to make sure that each of you have some input into these programmes going forward. So one of my questions of the board today is, how does the board want to be involved? And equally, individual partners sat around the table, how would you like to be involved? So the Get Britain Working white paper, have you all read it? I assume you're all familiar with it at least. So it talks about reducing economic inactivity. The government talks about 2.8 million people nationally being out of work, primarily due to disability and long-term sickness, and it also sets out its longer-term ambition to achieve an 80% employment rate. Part of that is obviously about driving down the benefits bill for government, increasing income back into Treasury through taxes and so on, but also about the wider health and well-being of the population. Being in work creates a better feeling for individuals. So the white paper talks about the 6 key issues I've got listed there. Talked about economic exclusion due to ill health, but we're seeing young people leaving education without necessarily the skills or ability to move into either further education or into employment. Particularly in Somerset, given our economic makeup, we see a lot of people in insecure, low pay, low skilled jobs. So how can we support those individuals? The white paper talks about women carers, significant numbers of women who have a caring responsibility who find it really difficult to get back into work due to largely inflexibility of work opportunities. The Chamber's not here today, but I'm sure they would support in saying that our employers struggle to recruit individuals into their workforce. We have a tight labour market already, so actually supporting individuals who aren't currently in that workforce back into work is something we need to do to encourage economic growth. So you've as you've alluded to, most of you have read the white paper, so you've picked up kind of some of those key issues that the government want to transform in terms of reducing waiting lists, transformation of job centres from a welfare office into a centre that actually provides employment support to individuals. They talk about joining up work, health and skills activity, and part of my role is kind of facilitating those discussions and bringing that activity together at local level. Youth Guarantee sets out how government wants to support young people as they transition from education into employment, and making sure that appropriate support is in place for those young people. And then
finally, in terms of our ability to get people into work, we need the support and buy-in of our employers. So there's a piece of work nationally happening to look at what support employers need to open up opportunities within their workforce for those with health conditions and or disabilities. So in respect that you've seen the paper that I circulated. When I wrote that paper, we didn't have guidance on the Get Written Working Plan. So this is a slight development since the report. So we've had draft guidance issued, which asks local areas, so Somerset being a local geography, to develop a local Get Written Working Plan. So a Get Somerset Working Plan for want of a title. So within that plan, we will locally set out how we propose to respond to those 6 key issues identified in the white paper. It's intended to bring local partners together. So as I said at the outset, individuals sat around this table, and also the employer voice as well. It's intended to be a 10-year plan, a local plan. We're not expected to have it signed off by government. It's how we want to respond to these issues locally. So in terms of that 10-year time frame, we obviously don't know where we're going to be in those 10 years. So there is opportunity for local areas to reflect and update their plan during that time frame. It will reflect the Connect to Work arrangements, which I'll cover off next. The council have been asked as a local authority to lead the development of the plan, and like I say, we will be engaging with key partners to do so. Helpfully, the time frame is a bit sooner than we anticipated and earlier than I alluded to within the report. So we've got 2 options. So we can publish a very high level plan by July, or we could submit a request to government and say, actually, we want to leave it and publish it in September. Don't think we've decided what time frame we want to work to yet, but part of me thinks let's just get a plan in place, let's kind of develop the activities and action plans behind that, and then because we're able to update and refresh the plan, we can come back at a slightly later date and kind of reflect on what we've done so far. So hence I've in my slides I've put July or September. So my ask really this morning of the board, and you don't necessarily have to answer now, but how would you like to be involved in the development of that plan going forward? Equally, how would the board like to be engaged in the overarching governance of that plan? It will be owned by a subgroup of the Somerset Economic Growth Board, but we do need to make sure that we've got representation from, many of you sat around the table today. Shall I pause there, or shall I carry on through my slides? I'm going to talk through the Connect to Work programme, so shall I go through those and come back? Brilliant. Okay, so here I've just captured our local statistics in terms of economic inactivity. I mentioned 2.8 million nationally being out of the workforce for long-term ill health. Within Somerset, we've got as at 2023, we've got 60,800 individuals who are inactive. We've also got fairly significant numbers of young people who are not in education, employment or training. So collectively, we will be supporting a significant number of individuals. We are doing a piece of work with the Health Determinants Research Collaboration sat within Public Health to get under the skin of these figures, working with the voluntary sector as well to get kind of community-based participatory research into our work. And once that information is available, it will help us determine where our priorities should focus. So of that 60,800, there's a breakdown. You can just about see it on your slides there. So we've got a
significant number of individuals who are students or in education. Potentially those students will hopefully move into employment, but there is a chance that small numbers will become part of that economically inactive cohort. We've got just over 10,000 individuals who are caring for family and home. 8,000 just over of retirees. So when we're talking about the 16 to 64-year-old population, those would be primarily early retirees, many of whom might be wanting to get back into the workforce due to cost of living and other factors. And then we've got those other two numbers, so 16,000 who are long-term sick and just under 6,000 who have other reasons for not being engaged. The national studies show that actually a high proportion of individuals who are sick or who have disabilities do want to work, but they struggle to get into work. So part of our Connect to Work programme is how do we support those individuals to access employment opportunities. So Connect to Work is the only funded programme under the Get Britain Working white paper that Somerset has access to at the moment. You probably saw within the white paper that there was a number of funded activities which are targeted at MCA, Mayoral Combined Authority Trailblazer areas. Somerset is not one, so we'll have to wait slightly longer for some of that funding to come through. But Connect to Work is a significant programme. As I said, it aims to support disabled individuals, those with health conditions, and those with complex barriers to employment. And there's a relatively long list of individuals that come under that complex barriers heading, so to speak. So carers, those leaving care, veterans, those who have been in prison and so on, and like I said, a fairly long list. So there is potential for us to support a wide range of individuals under this programme. Slightly technical here, but the delivery is based on a high fidelity supported employment model, and that uses two models: the individualised placement support. So within the health service, we already have a programme supporting severe mental illness individuals. So the IPS under this programme will not support the severe mental illness individuals, but could support those with other kind of mental health barriers and so on. And we also have the supported employment quality framework. So that is more of a community-based employment support programme. So under the IPS, we can support individuals for up to 6 months. So the idea is that individuals enrolling into the programme will be ready to work. So the expectation is once they are enrolled on the programme, within 4 weeks, they will be ready to participate in job search and potentially move into work quite quickly. So the wider wraparound support for these individuals is key to make sure that they are ready to engage with this programme. As well as supporting individuals, the support can support our employers as well. As I said at the outset, employers are key to making this work. In Somerset, we need to engage with those employers, and we are doing a piece of work with our employers, with the Somerset Chamber, to understand what support those employers need and how we can work with them to open up and widen their workforce participation. So we have a defined split that we need to work towards. So the target for Somerset is to move 700 individuals into work per year, which is quite a challenge given some of our local issues in terms of transport barriers, rurality, and other issues. We are asked to split our programme to support 75% of those individuals on an IPS journey. So that's a 6-month support journey, and then 25% onto an SEQF journey, which potentially can provide support up to 12 months. Additionally, we can support across that 700 up to 15% of individuals to stay in work. We're aware that there is an issue in terms of the issuance of fit notes and what that means for a person, being able to stay in work. We're still looking at the data in that respect. So for Somerset, that equates to about £2.87 million per annum to deliver this programme. So a good chunk of money there. But given our geographical, situation and the cost of delivering services in our rural areas, that's probably still a challenge to achieve those targets, I think. It's a 5-year programme, which is really good because that means we can kind of put in place and build up to achieve the 700 target. We aren't expected to achieve that 700 target in year 1, but DWP, Department of Work and Pensions, who are funding this programme, expect us to work towards achieving that target at peak. So probably as we move into year 2 and 3, and then towards the end of the programme, if ongoing funding isn't confirmed, we'll start ramping down. So there is potential sort of somewhere between 3,000 and 4,000 individuals over the life of the programme to move into or to stay in work. One of the key parts of the high fidelity model is to make sure that the individual is supported into the right employment, and I think that's really key to enable sustainability of that employment. What we wouldn't want to see is somebody being in work for a couple of months and then having to leave because it's not right for them. So key milestones I've just summarised into a simplistic table just to, I think, really show how busy we're going to be over the next couple of months. So the economic and activity evidence base is underway at the moment, like I say, through the HDRC and working with the voluntary sector. So the information will start to evolve from April, but we'll continue to do some additional work through the summer to continue to build on the evidence base. And it's something that we will continue to do through the life of the programme. We're aiming to submit our Connect to Work delivery plan in April, early May, and that will go through the council governance process and will hopefully be considered at the May executive committee. Get Britain Working Plan, I've put a star in of June, July, because I think that's where we should probably be aiming for. And then once the Connect to Work delivery plan has been signed off by government, we will start commissioning our delivery partners and we'll look to operationalise that plan from the autumn onwards. I would hope that we'll get first referrals into that programme from October, November. And I think that was my last slide.
Well done.
Thank you very much. In terms of the question, what can we do here, or what do we want to know about here? And my background is extensive in employability and complex lives, etc. I think it's about transport in Somerset for neighbourhood, all of the neighbourhood programmes, because if neighbourhood hubs are not accessible because there is no transport, some of the earlier plans this morning will struggle, but certainly with employability, the temptation is to start with the person that matches the criteria that have been identified as a priority. Having done it for years, I'd start with the bus route and who lives on it and what can we do about the employers at the other end of it. But transport, I know we touch on quite a lot, and I think it's asking transport to support neighbourhood health and to support employability, and what can we do at the county level?
Absolutely right, Angela. And it's a classic influencer of so many different things that we do, isn't it? Inability to get anywhere just stops people, but we've got to work on that. So Rima,
Thank you. I had a number of points. So the first was the need to work with the voluntary sector in terms of increasing the number of eligible adults. So we know that a lot of people need support before they're ready to look for work. And there's some great work going on with the voluntary sector to support those individuals. And then when they eventually get through their life traumas, whatever it is that they're trying to get over, the voluntary sector also helps them with things like interviews and getting ready for work. So I think whilst I really applaud your Connect to Work piece, because that's really important, if we kind of trying to look beyond the next year or two, trying to increase that pool of eligible adults at the same time would be really beneficial. And of course, it, you know, the NHS has also got a role to play. The thing I was going to focus on was youth. So a lot of youngsters these days don't have role models, so they assume that a lot of careers are just not open to them. And so I think we, as anchor institutions, really need to help them, whether it's going into schools, role playing, offering work experience. If I took the NHS alone, there are 350 different kinds of roles, including estates and marketing and communications and finance and. They don't all need to become doctors, nurses and other clinical professionals. The other thing that I discovered relatively recently is that if any one organisation doesn't use their apprenticeship levy, they can donate it to another organisation, and that opens up more opportunities. So I think there's a lot of work we can be doing together to focus specifically on young people.
Thank you, Rima. All taken here, absolutely. So if we go to Alison and then to Heather and then to Ewan and then to Claire and then to Dawn. Alison.
Good morning. So Alison Bell, Interim Director of Public Health. Thanks, Mel. I think this is a really critical issue for Somerset, particularly as you noted, that our working age population is smaller than the national average. And because of our demographics, actually, we probably need more people working to provide care and support to people that are more elderly. And actually, a lot of these people that are economically inactive are potentially in our workforces. So we've got real issues, I think, around long-term sickness amongst health and care, education workforces, but probably across the whole piece. So it's really timely. One of the questions you asked us was, should we go a bit later in feeding back to national government? And I think I would be really supportive of that, because we are doing this work with HDRC in the public health team and your team to really understand the reasons for why we're in this situation. And this is the third agenda item, third national template, third national set of targets that are imposed on us. And I actually think we need to take a moment and think, what are the real challenges we're trying to address? Because they're very different, like Rima was saying. For young people, I know we don't offer as many work experience opportunities as we used to, and that's without understanding what work is, why would you engage in it? So I think my caution would be, let's take time to really understand what the barriers are. I agree, Angela, transport's definitely one of them, but I think they're multi-factor and they're different for different cohorts. I think Ashley's just had to go, but in terms of probation, there's a whole set of different challenges, and we should be brave and actually say we need a bit more time to understand what the solutions are, rather than just rush in, hit a deadline and actually entirely miss the point of what we're trying to achieve. Thank you.
Thank you, Alison. And I, as you say that, there is something, isn't there, about local communities helping people who live in local communities get to work experience, and therefore owning the challenge within almost the carpool.
Thank you very much. I've got a couple of points to make, and I think Claire may. I'm sure Claire will come in on one of them. I'll start with the other one though first. Just when I went looking at the data, which is really helpful, what occurred to me, a couple of things. One is we're talking about doing a personalised plan for each person who becomes eligible, which will be massively intensive of time, but the right way to do it. When I looked at the data of the working aged individuals, it's women who are the biggest number rather than men, but disproportionately almost on some of the slides. So it's something about, you know, for those cohorts, 8 working age people, it's going to be the issues that before women. Which I hate being kind of, you know, discriminatory about it, but if you're going to go for the biggest number, that would be something to be considering. On the other side, on children, on the young people and children, of course, you can imagine our ears pricked up. And one of the things that I happen to have in front of me from looking at anyway is our Somerset Careers Hub annual report. And in that, as a council, we are already doing quite a lot from primary school careers, supporting children in primary schools, all the way up through as they start to look for work experience, and also issues around supported, or ideas around supported internships, which reaches out to some of our voluntary sector colleagues, the Young Somerset and other organisations that support those children who might find it harder to get opportunities to get into work. There's a lot happening, and we would love the opportunity to be sharing that with you. I'm sure Claire will probably put more flesh on that bone as well when she comes to speak. But I think that the NEET question, the not in education, employment or training, and just preparing children for education, for out of education for work, is something that, you know, we continue to work hard on. So those are my 2 bits. One was about working age women, and the other one was around the children's and young people's activity we're already doing, because it includes things like support for education providers, mock interviews, which were mentioned, working with teachers, support for employers. I was blown away when I first saw the effort that goes into through our partners and ourselves into supported internships for adults and for children, because it's not just setting it up, it's that thing about helping the employer to understand it, to make it as, you know, pain free for them to understand and take people on. So I just want to say those 2 things.
Thank you, Heather. Okay, Ewan.
So Ewan Jones, I'm Chief Executive of the Somerset Association of Local Councils. That's the city, town and parish body. So my question to Mel is basically, what is your ask of communities or localities? Just to expand on that. So Somerset is a county of communities and market towns. If it works well, each of those towns will have an active city, town and parish council. It will have an active business community, whether it's a chamber or another business organisation, local farming groups, etc., and an active VCFSC group. It could be called Carey Cares, or there's lots of them out there that are convening groups of voluntary organisations. They get together these days through local community networks, through the Somerset Council locality teams. There are 18 of those. If those work well, that is your efficient route to get the ask out to all of those organisations. So in your timing of sort of July rollout, I'd be looking at get on the monthly city, town and parish call before July to tell them what you're going to do, and get into the local community networks during the July-September period. Because yeah, transport is an issue. There are lots of other issues out there, and those are the places that those issues are being discussed in a way that's appropriate to locality. And just a plug on the skills point, if people, Summer Science, 1st May bank holiday at Haynes Motor Museum is a way where you'll be able to get in front of all of these people.
Pick that up and follow through, yeah?
Yeah, can I just come back on some of the other points as well, just collectively? Yeah, very aware that we have a lot of really good activity in Somerset already happening. So I think one of the opportunities through the Get Somerset working plan is to map out what we already do in Somerset, how we can build on that, where the potential gaps are for supporting individuals. I already work very closely with our education teams on the supported employment routes and internships, and one of our intentions will be to, you know, it's a tried and tested model. We know it works, we know it has a really good success rate, so how can we support that to grow and expand and widen that opportunity?
Thank you very much, Mel. Claire.
Thank you.
So I was going to go right back to the beginning in terms of primary schools and started to think about how we support children to want to get into that world of work so that we start to prevent this issue becoming an issue when children are adults. So if you look at the Somerset cohort of children with additional needs in terms of the SEND cohort, the biggest increase in that group is children and young people with social, emotional, mental health issues, and that encompasses autism in that group as well, and it's rising rapidly. So in terms of how we engage with schools and with young people, we obviously need to engage really early. Something about how people with neurodiversity are going to be able to engage in employment, so that they can see a pathway for themselves, I think is absolutely critical. And some of those SEMH needs also relate to young people who feel they have little hope for the future. So being able to engage with those young people early, so that then when they're in their primary age group and consistently, what we tend to do at the moment is do a little bit in primary school, a little bit in secondary school, and hope it all works its way through. There needs to be a consistent and building model so that the children can see their pathway through school into a future for themselves in terms of working in Somerset. Because we don't have a university, we have a massive brain drain at the end of secondary school. And we need to help young people see that there are opportunities for work in Somerset that require the skills of a further and higher education curriculum. There is a lot going on, as you said, Mel. I think one of the issues is it's all a bit fragmented, that it's not joined up, and we need to think of a mechanism to join those things up in one place. So we've already talked, Councillor Shearer has already talked about the Careers Hub. The colleges in Somerset are doing a huge piece of work at the moment on looking at what does their curriculum need to look like for the skills that are needed in terms of work in Somerset. Those two things are not very well joined up. The Shaw Trust is working as part of Connect to Somerset nationally. Connect to Work, they're working nationally, but are very involved in Somerset and the Homes and Horizons residential care project, and also working with care leavers through an innovation fund. That's a cohort of 400 young people who would all be able to access work if we got them into the right place. The supported internships you've talked about before, and it was really interesting to hear that the apprenticeship levy can be donated between organisations. That feels to me like an absolutely amazing opportunity to be able to get young people into apprenticeships in organisations who currently aren't securing those for young people. Thank you.
Thank you, Claire. You're going to get away with so many ideas, aren't you? Fantastic. Dawn.
Thank you. Yeah, Somerset councillor for Frome North. So there's a lot going on in Frome, but also opposition lead for public health, and everything that's been said really gets me excited, because my background is I'm teaching, but specifically vocational, and I think that it's interesting that we aren't bringing that stuff all together, and there's a network out there that is right at the heart of our communities, and that's 110 councillors. And we know our communities really intimately, as Ewan was saying about the parishes. You know, the parishes also have a role to play and know their communities, knows what's available, the jobs, the you know, all the skills that are needed in those communities. And then we've got an enterprise advisor network, which I'm a part of, and I think that plays a massive role really in getting into the schools. And Helen, I mean, Heather did mention about women, and you know, I'm a woman of a certain age, and menopause is a real problem for a lot of women, specifically women who have raised a family maybe and are now finding themselves in a space where they don't quite know where to go next. There's lovely focus on young people, which is needed in an older county, as we know, but I do think that there is a massive gap for women returning to the workplace and maybe finding inspiration. Or, you know, having the energy, just a little word, but it makes a big difference to go back into the workplace. So, yeah, those are just some thoughts that I thought about, that I think we could bring all of those together quite neatly. And there are organisations doing great things, but if we can bring them together and find out what's happening, that would be really useful as well.
Thank you, Dawn. Alignment is key, isn't it? We just try and keep us working together. Lisa.
Thank you. I think my dress probably introduces who I am. I'm not in fancy dress, but I'm the policing commander for Somerset and North Somerset currently. Do you know what, as the room's been going around, everyone's articulated it far better than me. I was going to talk about joining up the sort of the ideas, and I did a very bit
quick bit of maths, and I'm afraid I did read it, but not with as much time as I would have liked to. So I might have missed some of this, but when you do the maths, it's £4,500 per person. You're investing over 5 years. You're going to hit those targets, which is when you combine it with the complexity that some of those individuals you've raised, and I'm going to move away from the children's sphere and more into those complex adults. You know, that there will be other big pockets of money that is already wrapped around them in that fragmented way. If we combine it, we're talking, you know, tens of thousands per individual to really work it through. I really just wanted to make the point, and it's not to undermine the work, that fragmentation of investment in specialist help feels really stark still, and as much as it will take a lot more energy and thought initially, I think we have to do it, because if you're talking about £5,000 to £10,000 per individual to get them to work, to get them off addiction, whatever the complexity is, it could be well spent and achieve more than just this ambition.
Thank you, Lisa. Judith.
Yes, and some of you will have heard me say this before. Somerset has quite a high rate of exclusions compared with national, and they also have poorer attendance. Now, if children aren't in schools, they're not learning. And also, Healthwatch is concerned about the safeguarding aspect of this, because we all hear tales of children who are in some kind of pornographic. We wouldn't know. There's no way you would know. And I feel that what we are hearing today is a fruition of what has been going on for quite a long time in Somerset. And the value of education is not always seen. And part of that is because of the families they come from. But if they don't have those basic key skills and the knowledge that they could have a better quality of life through being in employment, we're not going to win the battle. So I think it's really got to start. And I know it's difficult with schools because we've got academies as well as state schools. But even so, there should definitely be a priority on this because, as I say, safeguarding is a real issue.
Catherine.
Just a very quick point. So we're currently working with partners to look at a vision for volunteering for Somerset. And on the face of it, it looks that it's around meeting the demand. Actually, there's lots of demand out there and we need more volunteers. But actually, I think there's something really important here about the individuals. And I think there's an opportunity here for us to do something really intentional around how can we think really creatively about what do young people need? How can we support their confidence, their connections, their skills so that they feel more confident to get work? It could be that we do some work with women who are coming back to the workplace and use volunteering as a mechanism for them. So it'd be good to have a chat, maybe Mel, about how we can. We can't do it all, but I think if we could start off and do something really intentional around volunteering to support people into work, I think that would be really good.
I think that's spot on, Catherine. Volunteer to work is a great route, isn't it, to get your confidence. Heather.
Thank you, and thanks, Judith, for mentioning the difficulty that we have in Somerset, which is around exclusions. I think it's the second worst in the country for exclusions and the third worst in the country for suspensions. It's nothing to be proud of, and it's certainly, and because of that, though, we are absolutely, we've been really determined that in the work that Children's are doing on transformation, it's one of 4 main planks to get back that issue that school is a protective factor for children, and that we have to have them back there. So we're really working on it. It's been really frustrating, but you're right. They can't get education if they're not there. And a lot of the work that we've been doing in the last year or so has been to improve. And you mentioned the different types of schools. We do have we've got a mixed economy of schools, as most places have. And we spent the last year trying to improve that relationship with schools so that, we have a better relationship between the local authority and the schools and that we can work with them. But yeah, that job's not done yet. So we just wanted to give you some assurance and give the panel some assurance and the board some assurance that that's a really key part of what we're trying to do. So if we work with you on the getting Britain working bit, an implicit bit of that will be keeping the children in school or trying to keep them in school. Thank you.
Thank you very much. I don't know whether there's anything you'd like to close out with, Mel, but
Yeah, I think it's a really good, the Get Britain Working Plan, whilst it is kind of focusing on addressing economic inactivity, it's a really good opportunity for us collectively in Somerset to really understand what our challenges are, and what's, what's out there at the moment, where the gaps are, and how we're going to kind of address this. And, as people around the room have said, connect to work isn't the only solution, it's one part of the jigsaw. How do we make sure that all of those fragmented services align, but working together to achieve those same outcomes for better kind of health and well-being across the population, making sure people are in good jobs? How do we make sure individuals have the skills for those jobs, and so on? So yeah, like I say, good opportunity and good timing for us to be doing this piece of work, I think.
Thank you. I would add, it's worth linking with Great Southwest and the enterprise board in that sense. And we're a county which is bringing employment in as well, isn't it? So how we work on that. Okay, if I may, we'll move on. I am deliberately squeezing Part B to much less time. I'm not completely out of control, probably mostly out of control, but there we are. I think we're having a good discussion. I hope people are valuing it. Item 8 is deferred. And item 9 then is to receive the health work priorities for 25-26. And Gillian, it's lovely to have you here. Thank you very much. Over to you.
Thank you very much for inviting me to come along this morning to talk a bit about our People's Vote. So, as you're probably all aware, I'm Jill. I'm the manager of Health Watch Somerset. Judith is the chair of our board. We're a statutory independent champion for people who use health and social care services across the whole of Somerset, so pretty much everybody in our county. One of our duties is to run a focus project each year, or several focus projects, I should say, each year on topics that are of particular concern to our communities. So during the year, we're listening to people, we're listening to their feedback, we're attending meetings like these. We're gathering together all this intelligence to inform our People's Vote. We have to share the process by which we make the decision on which projects we focus on, and you can find that on our decision-making policy. The link is there on the slide if you're interested in that. So for the 25-26 financial year, we've got a choice of 4 projects there. This will be in addition to a piece of work around pharmacy. That will probably be focused around what pharmacies provide in the county, how much people know about the provision that they can offer. And from the pharmacy side of things, I'm interested to know about prescribing pharmacies, and that was potentially going to be linking to dentistry, which is something we've obviously looked at in the past as well. So we've got 4 options there, and I think it's important to say, a meeting I've been at previously, that when we are re-looking at a particular topic, we also want to look at the distance travelled as a result of the recommendations that we've already made. So we do want to make sure that we are attributing the work that has been done on the back of a previous piece of work. So we've got 4 options there. Waiting lists for procedures. We hear a lot about people saying, well, I know I'm going to have something done, but I don't know when it's going to happen. Nobody's talking to me about this. This is something that we are revisiting. So I know that work has already been done, and I want to recognise that as well. The second piece of work is linking around hospital transport. We've already talked about transport. Another piece of work we're involved in, I'm looking specifically at transport for family and friends. This is looking at transport to and from hospital appointments. When they're booking appointments, how's that working? The third one is around transfer of care or discharge from hospital, and I'm aware of the piece of work that's being done in 100 Days at the moment with Somerset Foundation Trust, and the piece of work that's being done through the VCSFE sector, through the work with the Dementia Alliance, so I'm aware of that, so it'd be outside of that. We want to listen to patients and carers to understand what they think they need when they leave hospital, what information perhaps it is they think they might want, what support they might want, because I think quite often we make assumptions of what people want and what they need. I think we need to actually ask them what it is they want. So that's our third option. And the last option there, we hear quite a lot about mental health services in Somerset. We're aware of the CQC inspection with CAMS, and I've looked at access to CAMS. It's seen as the gold standard. If I can get over there and I can just have that referral, everything will be okay. We know that's not that straightforward. So we'd like to look at what help is given if people don't meet that threshold criteria. Where are they signposted to? Do people understand the criteria? I think it's about a 20-page document that CAMS have got spelling out who is eligible for their services. And I took one look at it and thought, wow, if this is what's going out to people, that's a real biggie. So that's our kind of fourth option. So my ask to the board this morning, please, is that you vote. There's an online link there. Smart survey, and my colleague has said, please, when you are voting, could you just put in the survey response that you are a member of the Somerset board, just so that we know how many people have actually contributed to our work plan for 25-26. And just one final thing, we do have to publish an annual report, our impact report. They are up on our website, and again, you've got a link there for the 23-24 report. Want to have a look at what we have been doing and the impact that we've had across our county. Thank you.
Increasingly, Paul, we're asked to do more work because of our independent status. And we're obviously will do it, but it is now getting to the stage, and I think the voluntary sector will say this as well, where we are getting so weighed down, we don't know where to go sometimes. So I think what needs to be looked at in the whole RCB funding is the funding of an organisation like ours, which is really based on NHS ratio, and we are top slice because we're what we call hosted, which reduces our ability perhaps to just employ somebody on a project basis. I'm sorry to be asking, I'm not asking for money per se, but I'm just pointing out the fact that we are willing to undertake, we have a lot of experience, and we obviously want to contribute as much as we can, but there is a finite line when we might have to start saying no. At the moment, we can't do it.
Afraid it's ever thus at the moment, yes. Okay. Presumably we don't all have to vote now, so we'll come. Otherwise, we'll all be spending hours trying to get into things. So if everybody would take it upon themselves to do that. But are there any quick comments or questions that anybody would like to put to Gillian in case they're not clear about the four options? Okay. So if we would all do our voting for it, Jill, thank you very much indeed. Anything last moment you want to say?
No, that's great. Thank you very much for your support.
Thank you. Okay, if we may, then we'll go on to the updates from the SROs, and we will start with Mel Locke and Kirsty Larkins on the housing and health issues.
So Kirsty's going to do this. I think she's got a few slides that she'd like to share with you as well. So I'll hand straight over to Kirsty, who is in the room, I know. Kirsty, we can't hear you online, so you may need to put your mic on or something.
Right, hopefully this one works. Yes, I can hear it's working now. Apologies, that always helps. So I know the board has obviously had many discussions, and I've looked back at past kind of papers and meeting notes on this subject. So, and I know it's very well rehearsed around the impact of good quality housing has on health and people's life chances. So I'm not proposing to kind of re-go over those. It's been very well documented nationally and also locally. I think there's some key parts that we're seeing across Somerset at the moment, and that's around increased demand for housing, and also a real increase in rough sleeping. Again, I don't think this is any news to any of the agencies, but we are experiencing more complex individuals with multiple needs, and I think that's seen across the whole system. So I think there's some sort of startling stats that we've seen over sort of 22, 23, 23, 24, and that's a 16% increase in homeless assessments. We haven't obviously got the full stats for this year, but we think that has gone up again. We're seeing 24% increase in the number of households residing in temporary accommodation, and for the majority that is bed and breakfast accommodation. Or hostel accommodation, and then we do use obviously self-contained, but I think it's 55% are in bed and breakfast accommodation, and again that impact that has on those life outcomes and people's health is huge. Against that backdrop, we've seen a 1% growth in housing stock, which obviously is not keeping up with the demand that we're seeing through. We've also seen in that period of time a 40% increase in rough sleeping, and I've got some more stats that I'll go through shortly. So I think what's shocking for me is we were the 6th highest nationally in terms of rough sleeping, and for a kind of large rural county that seems really quite shocking. I think when we did our count in November, we found 80 individuals rough sleeping, which is a 40% increase from the previous year. We know 94% of those people had multiple needs, 87% with mental health needs. We've seen obviously a massive increase in those physical health conditions and disabilities. Also more presenting as neurodivergent or have declared to us that they're neurodivergent. I think we suspect there are more than that. Increase in drug use, increase in alcohol use. And again, I don't think any of this is kind of a shock to all of you in the room. You will have seen that reflected within your own organisations, but put together, it does create a very complex picture as we move forward. So just to sort of switch around that demand and supply for social housing, you'll see we've done some modelling around if demand stays as is and compared with the number of properties we have become available, that we will really struggle to keep up with demand. And at the moment, we don't have sufficient 1 and 4 bed properties available to meet that sort of gold band highest demand, which again is quite shocking to find where we are. And then for all properties, if demand continues and supply continues, we won't be able to meet emergency and gold band supply by 27, 28. We have got that kind of perfect storm in Somerset with private sector. Fantastic that we've got industries coming in, which is brilliant for our economic development, brilliant for job prospects, but that does have a marked impact on where we are with available private sector housing and affordable private sector housing. That set against as well no increase in local housing allowance for those people that are reliant on benefits creates a huge divide around affordable, suitable housing. So even kind of with that, and then looking at the supply of social housing that we've got across the system, we really are in a dire situation. I can't emphasize that enough. And hopefully the graphics there quite nicely show, I think it's one of my sort of not favourite in what it says, but favourite and in its clarity of what the one on the right hand kind of shows and how long it would take to house everybody currently on the housing register. So again, if kind of things stayed steady, 8 years to house everybody in a 1-bedroom property. You know, it's really stark. So I think there is ongoing work that partners will be aware of. So we've formally adopted the homeless and rough sleeper strategy, and we are developing an action plan with the Homeless Reduction Board driving that and focusing on the 3 principles in the strategy, which is increasing early help and prevention, ending rough sleeping, and then suitable and affordable accommodation and support. And that support has become even more critical now. And I think the tide is changing with kind of mood music from the government around that support. It's always been around doing some shorter term support, kind of 6 months. They'll all be sorted and they can sustain that tenancy, and off you go and start supporting someone else. I think what's been realised is the reality of the complex individuals we're dealing with need much longer term support, and in some cases may need that for the entirety of their kind of life, sadly, because they don't have that level of skill and ability to sustain a tenancy successfully. So in a way, it's good that that's been recognised, and we need to start obviously planning for those longer term support needs across. And then obviously there's the cross-cutting theme around committing to hearing and acting on the voice of lived experience. And then obviously nicely linked here is the health and well-being of that cohort that we're working with. We're also developing a homeless charter, and we will share shortly with agencies. Again, for me, that's about, lots of people talk about housing being really important, and I think we all recognise that, but we actually need some actions moving forward here. So it's about recommitting to those actions and starting to move some things forward. We're also in the process, our planning colleagues, around refreshing the county-wide housing needs survey from the local plan. It's important to say the statistics that I've provided around social housing, so they're the known numbers. We know there's a lot more need out there, but many people don't register on Home Finder, don't kind of do that. So there is a much higher need than indicated. So as I've mentioned, some of the challenges we experience is that a lack of affordable and suitable housing. So we've got some good schemes that we have set up. We've done some great work with children's around the Thrive 16 plus accommodation, which is great at meeting that initial need. But what we've got then is that next step. How do we move those young people successfully on to accommodation? We've got some good work around some of our rough sleeping and getting people in. But again, it's finding those housing first solutions, those longer term solutions, which we struggle with. We have had some issues around accessing services to support with securing and maintaining tenancies, and it's about that longer term scenario, so not the short term. I think agencies generally are quite good at coming in and kind of parachuting in the short term, but that longer term scenario. Kind of internally for us, we've not focused enough on preventative services. So we had some very good preventative services around homelessness. That slipped, and we've turned into firefight mode. That then just exacerbates the issues. We've got some work in progress around how we're going to tackle that and starting to change the way in which we work. So we are working much further upstream, but also hopefully successfully using some of the data that we have available to us, so we can start working with individuals perhaps that before they even realise they are at threat of homelessness. So really kind of much more upstream. So some of the things that come around are links with the Homeless Reduction Board through the Somerset Board, and how we link that together, how Homeless Reduction Board feeds into the Somerset Board. So it'd be great to have some feedback around what the board would like. And then I know there is ongoing work around joining up data intelligence, but it'd be great to include some of the housing data. We've got some rich data as well, and including that and layering it with other organisations' data. I think that's key around that preventative work, identifying the trends, making sure that we're aware of things as soon as possible, able to successfully measure outcomes. We want to be able to trial things and know they've worked, rather than kind of a bit of guesswork in some of those, and use that to allocate resources. So we've not got millions of pounds, but we have received additional money around rough sleeping. So it's helpful to obviously then be able to use that in a targeted way. So solutions around some of those challenges are co-designing and co-commissioning of services, and we've started doing some work in that space, but there's lots more to be done. Pooled budgeted pilots for complex clients. Again, we've done some very small pilots in that space, but not anything huge. Developing equity of service across Somerset. We still don't have that in some spaces, especially around drug and alcohol, where we struggle to recruit into some of the vacancies. And then ensuring we've got the right services in the right places to meet the needs of our communities. And that for me is around that analysing and sharing of that data and that rich information each organisation's got. I think as well, just to say on sort of a more operational space, we are just about to fund a dual diagnosis worker for assertive outreach. So great, again, that kind of cross system. We recognise that's an issue around our rough sleeping cohorts, that kind of cross system. And we're also, which is exciting, not quite there yet, but we've got funding that we're using for our rough sleeper money to recruit 2 social workers from adult social care. And again, it's about that joined up assessment across the system and making sure those complex cases don't fall between the gaps. So they'll obviously have that ongoing support from our adult social care team, but they will be embedded within the housing team. And I think that will really help across those 2 areas of work. So it's quite exciting to see how that develops, and that's going to be a pilot for a year, but our hope is it will be successful. We know it's been successful in other places, so there's no reason why it shouldn't be. And then if it is, embed that as part of kind of business as usual as we move forward. So I think I've mentioned these are sort of the asks for the board. So how you'd like the Homeless Reduction Board to update the Somerset board, that commitment to housing, which includes data sharing and analysis. I know there has been a commitment to housing and health through this board. And then around moving acute treatment community linked services to support complex individuals to remain in their tenancies and to continue to develop the multi-agency model. So we have got creative solutions linked to complex individuals, which has been a pilot, but I think there's some more work to be done in that space as well, and making sure we've got the right professionals around the table, and they're the professionals that can make those decisions for the organisations and be able to drive those things forward. Thank you.
Thank you very much, Kirsty. I think we've lost Mel, haven't we? I think she's had to leave the meeting. Oh, no, you are there, Mel. Well done.
No, I am here. No,
Thoughts,
gone
please.
nowhere.
Mel, over to you.
So I think for me, it is about us understanding where we've got to, being clear about that, and then the ask of you, which is what we've asked for today. I think that's probably about as much as I need to say. I think the rest is covered by Kirsty.
Angela.
Thank you very much. I wanted to bring this back to the first presentation, the joint forward plan, and Rima's observation that maybe we would do well to look at deep dive on frailty. I would suggest start to record the housing status of your frail population, because at Citizens Advice, certainly we are seeing rising numbers of older people renting privately. So we instantly know they've got less secure homes, but also adaptation and support to stay independent might not be as easy. So I don't know if you record that in the data sets, but I think, you know, the housing status of all of the people we're concerned for would be useful for us as a county, because I think the trend was toward privately renting. As that stock is reducing and competition for it increases, then we have people coming into at risk of homelessness that we've never seen before. Thank you.
Thank you, Angela. You want?
So there are very few. There are some people who are older that are coming into our housing stock, but not that many, I must admit. And aids and adaptation shouldn't be a problem, because we have a DFG grant where it is appropriate to do that. So I think we need to think that through, but I wouldn't disagree with you in that space.
Thank you, Mel. David?
Yeah, I'll update in a second on the Improving Lives platform and the work that's being done there, because that is focusing on frailty as the kind of use case initially. So I'm happy to take away, because the intent is to try and define what indicators you need to look at in order to support people with frailty in a particular subset. And that, you know, take that back in terms of your recommendation around the housing status. Angela, thank you.
Thank you, David. Heather?
Thanks very much. I've been really intrigued and bothered about what we've been doing as a council for some years on homelessness and supporting the complex individuals within that. I suppose a couple of things just occurring to me is, with my kind of children's hat on, because I think if there's not just adults in there, there's families that get involved as well, or disadvantaged through the housing is another, and like an anti-protective factor, if you know what I mean, or an indicator. So for children as well as individuals. But I was just thinking, okay, I know we've been working as a council and across the system to create this data sharing thing called Transform Family View, which is trying to pull in data from health, from ourselves and the council, from the police, to look around, around vulnerable families. And I just thought, oh, what do we do about housing with that too? And is that click there? And I don't know the answer to that, so it's out there as a rhetorical question for us to follow up subsequently. I think that's important. Similarly, I've been working with my kind of community safety hat on, with protecting children and young people from exposure to violence or involvement in violence. So I can work with Lisa and with Ashley and other partners as close as we can. I'm just thinking, when we're trying to identify those children, people, families, whatever, we get soft data, or there is soft data all over the place, and we try to pull it together so we find it quickly. And I don't know whether we're asking our housing colleagues about that. If I think about some of the things I do with my community safety partnership hat on around, and not necessarily perfectly, but around, say, domestic homicide review, and you look through all the partners who come in to help us if somebody has died within a domestic homicide, a domestic situation. And housing is often involved. So I think just want to make sure they're not an afterthought, that we have housing and the intel that's coming from our housing colleagues in as early as possible as well. So that might be around, say, I'm not sure it's in priorities meetings, I'm looking at Lisa, but that kind of thing of what we do collectively to discover people before. We're great in a crisis, we want to find them before they get in a crisis. And it's whether we've got housing at the table. So just a thought.
Okay. Take that away, yeah? Alison?
Thanks, Kirsty, and thanks for all the work you're doing, and to Mel for the support. I think we're already seeing the benefits of being a unitary council and being able to join up some of the opportunities. So I say this with my chair of the Drug and Alcohol Partnership hat on. So, and it's really about how we're tackling inequalities. So the statistics you share are staggering, really, aren't they? About how many people are facing homelessness, and we know the health impacts for those individuals. But when we've got a shortage of supply in terms of housing and homes, it's often the people that are most marginalised that are least likely to get a house. Now, I don't understand gold, silver and bronze, except for with swimming medals. So, but what does a bronze person look like? And are those the people that have drug and alcohol needs? And if they're not, because Mel and Kirsty both shook their heads, then how are those people with substance use issues ever going to get a home if we can't reach even gold people?
Yeah, thanks, Alison. So bronze are those people that are in low housing needs. They might be privately rented without a long-term secure tenancy, so it's the much lower housing. Then silver, simplistically, is those in medium housing needs. They may be lacking a bedroom in their current accommodation. They may have had notice. They may be threatened with homelessness. And then gold is where people have either got severe disrepair in their property, they're owed a main housing duty by the authority, or they've got high medical needs for movement, and then you've got emergency bans, so they're things like bed blocking, or someone that's experienced domestic violence needing to move very quickly. So it's kind of where it comes from. So many of those clients that you're describing will be in gold band. The issue we have, though, is around them being able to access housing. So understandably, social landlords are more cautious about who they take on. They do tend to be sadly less less desirable tenants, if you like. So in theory, people will bid on a property, and if they're not able to do that, the system can do that for them. So they're not reliant on having to do that. And then it's the person that's in the highest band that's been waiting the longest period of time that will be allocated it. But by the very nature of those people experiencing drug and alcohol issues, and often mental health with that, they tend to be quite chaotic, and it can be quite difficult, obviously, to make that connection with that person. And so sometimes they are, you know, it goes down to the next person on the list. We are doing a lot more in that space around outreach with our rough sleeper cohort as well. So we've got some more funding that we're looking to address that. We've got some funding around Housing First, which should take away that need to kind of meet lots of criteria in order to get housed, because quite often they are barriers to people becoming housed. If people are living rough on the street, they don't have rent in advance, they don't have white goods, they don't have those things that they need to kind of go into a tenancy. And on a positive note, many RPs have agreed and kind of signed up to those Housing First principles, which is great. What we are not seeing, though, at the moment is sort of properties being identified and coming through quickly enough to kind of meet that demand. So we are doing some work in the private sector. So whilst it is challenging, we do have some landlords that do come forward and kind of want to kind of have a social impact. So we're doing more in that space as well, and using some of the funding that we've got to kind of make that client group more desirable, if you like, and less risky for that person to take on and offer that opportunity of a tenancy.
Yes, thank you for that, Kirsty. It is really, really complicated, and I guess the board probably understand this from different perspectives, but to enable someone to engage in their treatment, they have to be near a pharmacy on a daily basis that can support their treatment. And because pharmacies are withdrawing or stopping service, we're having huge challenges in this space. So more to do.
Yeah, and it's not getting any easier, but you're right, it joins up. If I may, we'll draw it to a close. I'm not sure we've answered your asks particularly, but it may be that we need to take those away and make sure we come back to you outside the meeting, if that's all right.
That would be helpful, thank you.
Is that all right? Okay. The next couple of items, with the next two or three, we've sort of covered to some extent earlier on, but David, I'm sure you're going to take us through quickly what you want to make us sure we pick up on where we've got to. Over to you.
Yeah, I noticed the emphasis on the word quickly there, Chair. I'll try and meet that expectation. So we got I'll get two updates, and then we've got a shared update on the neighbourhoods piece. When we met the last time, we agreed that we would develop a sort of true north measure around outcomes and around healthy life expectancy, and that would be the kind of the guiding North Star to which we want to be kind of measuring ourselves against over the longer term. Since then we've explored a number of options around how you define that and measure that. I'm happy to go into as much detail as I am capable of doing, particularly with Alison sat at the other end of the table. She might need to pick it up from the layman's interpretation. We have settled on a measure which is around the proxy being used is the average age at which somebody develops their first long-term condition. So that is deemed to be a kind of a good proxy for healthy life expectancy overall. The current way we're measuring healthy life expectancy, I should have said at the start, is not continuing, and certainly it's not sort of, we haven't got enough data to meet that standard, so therefore we've had to do a bit of rework around it. So the second task is, if that's the measure we're using, is okay, well, what's the current baseline against that, and then what's the improvement we want to make over the longer term is the two pieces of work. So I'll say we'll probably bring back a fuller briefing the next time we meet. The headline really is the fact that although they measure at the minute for males, for instance, within the area, that the last measure, which was the Q4 22-23, the average age at which they developed their first long-term condition was 52.8 years, and for females it's 49.8. I think the fact is that when that was measured 5 years before that, instead of being 52.8 for males, it was 54.7. So in fact, people are getting younger and developing their first long-term condition. So therefore, we need to be careful in setting an improvement trajectory moving forward. It's there for my earnest colleague at the end. So we've compared to, and certainly Alison's team have compared against upper quartile and upper decile nationally. And we are sort of centering in and honing in on the fact we should move to upper quartile in 5 years' time. We just need to do a bit more work just to reassure kind of what that looks like, and particularly some of the unintended consequences as we seek to try and improve our recording of chronic conditions, and therefore that might work against us in some ways. But we've got to do the right thing for the people locally. So that's where it's up to. That's the headline measure. We have all been involved previously in sub measures and the indicators, so they are there. It's about mobilising those now and getting those put together, the head measure and the sub indicators. So that's the layman's interpretation. Do you want to add to that, Alison? Right, thank you for that. I'm just happy to take any questions on it, but that's where the work is at the moment. The Pop Health platform, so Lucy did a presentation. Lucy Laker is the joint post between Health and the Council. And she did a presentation at the last meeting on the development of the Improving Lives platform. She is at the moment trying to secure a technology partner then. We've just approved that last week, so they should start in the next 2 weeks by the end of the month. And they will undertake a 10-week sprint, and they will try and work out how technically you pull the data that we need for frailty within that neighbourhoods piece, and build up a view, a population health management view of that cohort. So that's a functionality we don't have locally at the minute. That builds on the work in terms of the Transform data lake that's in place already for children's in the area. So she's working closely with that team. So that kind of gets us off and running with that. And as we said at the beginning, it's about trying to overlap all these pieces of work so we're not doing separate things. And that initial piece of work will take place because she's been doing concurrent work around the information governance aspect to it. So that initial cohort of frailty will start off with the symphony practices, which are all under the leadership of Somerset Foundation Trust, and that helps with the IG initially to work out exactly what the data set is, and then we can extend that out to other practices in the area from a health point of view. So we'll do a fuller update the next time we meet on that one as well. Do you want to lead or? Yeah. I'm happy. Yeah, I'm happy to start. That's okay. So we have got, there's a raft of pieces of work undertaken within health at the minute. We've got coaching within West Somerset around trying to bring the teams together around common goals. We've got work taking place in Shepton at the moment around the estate and co-location of teams and trying to scope options there and develop a business case around that. We've got to sort of outline business case stage. We've got wider work across the Mendips at the moment around improving access to general practice as part of a national pilot. And there's a whole host of work inside Somerset with those symphony practices, which are tied to Somerset Foundation Trust. So there's a whole host of things that are going on. One of the challenges I've talked about previously is how you simplify that and describe that and put a framework around it. And we spoke last time about, Jonathan presented this sort of trellis framework, which gives us sort of the right data, the right governance, and the right support in terms of role developments. So as Paul has indicated, we're using frailty to test that out, and that work is being clinically led, as Burge touched on earlier. And as I say, they're focusing on not these traditional aspects of frailty, but around the loneliness and isolation aspects in particular. So that kind of is a test case for it. I think some of the challenges that it's not going quickly enough, I think is probably where we're at with it. So how can we add pace to that? This work does take time, but it feels like we should step up and do more quicker as we move into next year in particular. So we're giving some thought as to kind of what resource we've got to put to it to enable that to happen. The data will help. So once Lucy's got that plumb through, that'll help guide the work. But there's going to be lots we can do around that in the meantime. So that's our within, from a health point of view, we said the emphasis is on trying to join the clinical teams and bring them together. We've also indicated that there's a number of trains running with regards within the patch from a local communities point of view. So it's not just about health, but also then with the Connect Somerset piece from a children's point of view, and then also with the LCNs and the work that Ewan's leading on that. So the challenge I think we still have, that we haven't solved, is how you describe that simply as one sort of stream so that the local communities can engage with it more easily. At the minute, it is still sort of 3 or 4 programs probably running, but maybe more depending on your perspective. And that's the challenge we're facing into at the moment. One of the key bits at the heart of that is what is a locality, what is a neighbourhood, and some of the economies of scale around that. But that's been worked through. So I think there's progress in individual areas. The question and the challenge I think we should be held to account for is how we bring it more easily together and easily describable and simplified for the local population. And that's the work that we're sort of facing into now. I don't know if you want to pick it up from there.
So the other bits of that, so I completely agree. We've got all these different projects running, and we need to be held to account for how do we make that one sort of overarching model. At the moment, we've got several models running. So the other bits that are also running is, we've obviously got Lisa here from the police, is the police are about to restructure into neighbourhoods. They're likely to be the sort of PCN Connect Somerset type footprint, which is great. But in terms of the model, in terms of the multi-agency working model in those areas, that's not agreed or even at the starting blocks really to some degree. And then we also have overlaying that 2 other bits of national, being directed by national again. So we've got the national social care reforms for children, which requires us to move to an early help model and to work in locality areas with multi-agency child protection teams and multi-system staff in those teams, including drug and alcohol, mental health workers for adults, etc. So children's social care are being driven by the Department for Education down that line, which works with what we're already doing. It's not a problem, but we do need to integrate with the whole system. And then there's also an NHS guidance that's just been released in relation to children about 2 weeks ago about multidisciplinary early help. I think it's called neighbourhood working in relation to children, which is very clearly directed from GPs, to be led by GPs, and only to work with children with the most complex disabilities. And it even gives a timescale of about 1 hour a month. So it's the whole system nationally is not aligned. That the Home Office has also issued something in relation to prevention partnerships, which is just for 10 to 17s at risk of criminality, working in locality areas. So I have pushed back nationally at through the Department for Education to say all these different bits of system nationally are not talking to each other. The Home Office, the DOH, and the DfE are not having a conversation about what do they mean by prevention, which is probably partly why we're struggling locally, because we've got all these national directions that are going different places. The Department for Education and the DfE have agreed that they will issue cross-departmental guidance about localities, neighbourhoods and prevention in late spring, so I'm assuming May probably, which might help us in terms of direction across the system. But at the moment, the local position is probably reflecting what's going on nationally. And we will probably be better to try and work out what we want to do locally, because it doesn't look like the national picture in terms of direction nationally about the whole system is going to come very fast, if at all.
Spot on. We need to own our future. Absolutely it. So we need to pull that together. But Catherine, maybe you want to add something.
I'm just going to give you a quote first. So I saw this the other day. I'm not saying I'm a massive fan of Stephen Bartlett, who wrote the Diary of a CEO, but this came up on my LinkedIn the other day. Most people already know what they need to do. They don't need more books, podcasts, or courses. They need more courage. Procrastination loves to hide behind planning. Breakthroughs happen when preparation ends and action begins. And I just thought I'd share that, because I think we all agree with that. And I think it's how do we move to action right now, because I think the fact there's 4 SROs for this demonstrates that this is really complex, and I think there's loads of brilliant stuff going on, and it's how do we enable communities and neighbourhoods to have the power to decide themselves what they're doing. So there's a couple of points I also wanted to make. I think we're doing some volunteering pilots through the Volunteering for Health programme. So I've mentioned this previously, I think, but we're one of 12 areas nationally who got funding for that. So we're working in Frome, and we're also working in the Rural Practice Network based at the Balsam Centre. And what I want to use those pilots for is to look at how can we engage community organisations and volunteers and communities. What could we learn from those 2 pilots that we can then use to help enhance the neighbourhood working as well? And I think that brings me to another point that I wanted to make. I think there's a real live strategic risk at the moment that I think it's really important that I raise at this board. NHS England talks about moving from hospital to community. We're talking about neighbourhoods, and we all absolutely recognise why that's a really good idea. But I think rising demand at the moment is having unintended consequences for communities and the voluntary sector. I'm having several organisations a week coming to me, and again, I've raised it before, but I want to raise it at this board, saying we can't cope anymore. And so we've talked at the neighbourhood board before, haven't we, about there need to be two distinct strands for the neighbourhood work. One is around multidisciplinary teams and the stuff that we've just talked about here, but then there's something around how are we enabling and supporting thriving, resilient communities, how are we ensuring that we're supporting communities to take care of each other, and that is as important a piece of work as the multidisciplinary work as well. So it's how do we start to have those conversations as well, because as I say, I think three issues that the organisations are talking to me about: massively anxious about safeguarding and the fact they're dealing with increasingly complex people within community spaces and not feeling supported to do so, workforce burnout for volunteers and for paid staff working in voluntary sector organisations, and also just this idea of funding. So I met with an organisation last week who are between a rock and a hard place. They've got lottery funding that's about to run out. They're seeing 250 young people a month, supporting them with counselling. They can't get statutory funding, and they're told by other funders that they won't fund them because what they're doing is verging on statutory. And I had a really brilliant conversation with commissioners at the ICB, and absolutely we're having those conversations and there's a recognition. But I just think it is a strategic risk for us as we move towards neighbourhood working that we have to very quickly start thinking about the unintended consequences of pushing into the community.
Thank you, Catherine. Ewan, do you want to add anything?
Apologies. One thing I would add, actually, to Claire's point about geographies. I went to the National Association Parliamentary Reception last week and met somebody from the HCLG, is the right order these days, isn't it? They're very much on the case of the need to align in the devolution white paper with all of the health boundaries, and would be very interested in using Somerset as a case where we've gone through unitarisation already and how they make that work. So, potentially in a few months we might get her down here to meet the various teams.
Thank you, Ewan. I often think that we need layers and layers of the map of Somerset with everybody else's different things. And if we look at it, the cause will be clear. It's the boundaries on the edge that are probably blurred, because the people are where they are, aren't they? Some way.
And I'm off to the Balsam Centre after this meeting, so I'll ask them about volunteering for help.
Okay, I'm going to be very quick now because we are really out of time. Alison, quick.
I just wanted to thank Catherine for flagging that we do actually need to acknowledge the elephant in the room and the fact we've still got a lot of work to do around neighbourhoods. The NHS plan that's coming, if we are serious about prevention, is likely to have a whole nother layer of demands around prevention in neighbourhood areas. So how you've described it is really helpful for me, like resilient communities and MDT working. But if we're really going to shift to prevention, it's no good just our services be involved in the MDT working. We need to do prevention actually as part of that, and we need to make sure that's embedded in the resilient community work. So thank you. You've got it in my head finally as to how it could work.
Thank you very much. Lisa.
Just very quickly to put the clarity on for the board, because Claire did reference what we're doing, and I didn't want anyone to run out of here thinking that we're changing the boundaries of Somerset policing. But we do have to. We've been given the neighbourhood guarantee money, of which is only 4.8 million for the force to uplift neighbourhood policing. So we're only talking single figure officers and PCSO increases in Somerset. But knowing this is very much on the table, we're trying to use the opportunity now, because we are reshaping to equip for that, so that we will redefine our boundaries, because policing still works very much as east and west Somerset, or it's probably looking like, in order to make sure that we are absolutely coterminous, because only in being coterminous with such a finite number of resources are we going to achieve the list that Claire rattled out, as well as all the other things that we're trying to do. So, Somerset East and West will suddenly become Somerset Central and South, I think, in all that we can do it. So we are forward thinking, albeit not with an awful lot of money or change, but I do think it's a great opportunity.
Thank you very much, Lisa. Okay, well, there's lots to do there, but I think we'll come back in a minute to the programmes. If I may, we'll move on because we really are almost out of time. Item 11 we're going to touch on in a sec. 12, there are a number of items to note there. Everybody content with that? I don't know if anybody has any other business before I close the public meeting. No? Very good. In that case, I will close the meeting, and the next one is to be held on 25th of June 2025 here at 10 o'clock. Now, I'm absolutely certain that people would like a very quick comfort break before we do part B. So it is 25 to. Can we be back just after 22, please?